Intermittent fetal monitoring. A legal disclaimer we put at the beginning of all of our presentations: this information is general and educational use only. The contents are meant to not substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. Course objectives: the students will be able to verbalize what exactly is intermittent monitoring, because I think in the labor and delivery units they get super confused on that concept, the timing, and what machines to use. So I think we have to go to the basics of this conversation. The students will be able to verbalize the different instruments that are available for intermittent monitoring, and then the different techniques for performing intermittent monitoring. They'll also be able to talk about the recommendations based on how to perform intermittent auscultation. There's an art to all of it, with sound and position and pressure, and you're in the water versus she's in hands and knees versus she's laying in semi-lithotomy. Like, it's going to make a difference with intermittent monitoring. You're actually getting mom's heartbeat versus baby's, and then baby comes out and is not having a heartbeat for a while, and you think that you're getting the baby. So there is a skill and art to all of this. Being able to tell the difference between normal and abnormal heart rates, and how to manage those abnormal heart rates. This topic is really important because low-risk healthy women should be on intermittent monitoring. That's the standard of care. But unfortunately, in the hospital setting, most moms are on continuous monitoring because of staffing and convenience and the medical model. I want us to get more and more intermittent auscultation during labor. There's less interventions, there's less complications, there's lower C-sections. If they're low-risk healthy, it should be the normal. Continuous monitoring should be flagged as their high risk, and we need to keep an eye on the baby all the time. And most women that are low risk should be on intermittent monitoring. In the home birth center setting, this is the only thing. They actually don't even fit birth center criteria on a national standard. If they do a non-stress, they test, they do a continuous monitoring at any point during labor, they can't actually be a nationally accredited birth center. So that's telling you that if they're that high risk that you should be doing continuous monitoring, they shouldn't be in the birth center setting. The different positions and how to monitor, what's more favorable to listen, the timing, there's guidelines out there. You have to be able to give one-on-one support for these families, these mothers. So in out-of-hospital birth, it's much easier than a labor and delivery nurse in a busy unit where she's taking care of 2, 3, 4 people and there's emergencies happening. They put the babies on the monitors because they can have a central person at the front, their charge nurse, watching all these mothers and babies, versus you have to have one-on-one support when you're doing intermittent monitoring, and a lot of labor and delivery units don't have the staffing to do that at this point in our healthcare challenges. You want to be able to facilitate the assessment of the overall parameters, like how's the mom doing? Like if you're getting heart tone issues, late decelerations with baby, but she's having panic attacks, she's not breathing well, she's sweating, she's running a fever, the heart rate is up on baby, the mom's heart rate is up, there is good fetal movement, there's not good fetal movement, there's a short break between all the contractions, especially in the hospital when they're inducing them and they're on Pitocin. You can stress out the babies and cause things to happen, versus maybe the cord got kinked and repositioning solved the issue. So you have to look at the overall situation of, we have normal heartbeat, we have an abnormal heartbeat. If we have an abnormal heartbeat, what are the possible things through my head I can do to figure out if it's one thing versus another? So let's go to the basics. What is intermittent fetal monitoring? It's the fetal heart rate being documented at least 15 to 30 minutes during the first stage of labor, and then 5 to 15 minutes during the second stage of labor. If you're hitting a point where you need to do continuous monitoring, you're going to use what's in the picture above, the continuous monitoring. And I think a lot of labor and delivery units, they think they're intermittent monitoring because they'll use this EFM system versus a Doppler and trace it on the paper, and that's not actually what's recommended. You should be using a fetoscope or a Doppler. As soon as you use an electronic fetal monitor, that is meant for continuous monitoring and gives a different tracing and interpretation. So we have to be very careful of this confusion. Just because I'm taking it on and off, if it's a continuous EFM system in a labor delivery unit, you really should just keep that on. If you're going to do intermittent monitoring, use a Doppler, use a fetoscope. So the technique can vary based on baby's position. If baby is breech, you're going to be getting your heart tones. You get them on your baby's back. So if the baby's back is higher in the mom's abdomen, you're going to get heart tones higher, versus if the baby is head down, especially during labor, you're going to get it in the lower right quadrant, the mid lower abdomen, or the lower left quadrant. And then especially when it gets close to pushing, the baby's heart rate is going to be pretty much right over the symphysis pubis and around the pubic bone, because that's where the baby's chest is at that point. So you have to have the art of Leopold's and knowing where the baby's back is, and the feet, and the butt, and the head, to know exactly where to put the monitor, versus you're just guessing and searching everywhere. You want the optimal place where you're most likely going to hear the baby's heartbeat the loudest. With intermittent monitoring, you're going to do it 1 to 2 minutes during and after a contraction. Sometimes it's harder than others. If she's in natural labor and she's moaning and groaning and she's hip swaying and she's constantly moving, you're going to do the best of your ability, versus she has an epidural, she's got high risk, you're going to have a continuous monitor. But when they're moving and they're making noises, you're going to have to work around the mom and listen closely to the Doppler and the heartbeat. Because if you have a dip in the heartbeat during a contraction, that's an early deceleration, that's head compression, that's a good sign, it means baby is coming soon. If you're having a dip in the heartbeat after a contraction, that's a late deceleration, and that's those signs of oxygen concerns that we definitely want to follow up on. Could it be because of cord compression? Could it be because of placenta insufficiency? Could it be because she's not breathing well and getting good oxygen? Is she dehydrated and needs some fluid? Like, there's a lot of things. Repositioning, is the cord getting kinked? That tends to be more variables and prolonged decelerations when you have a cord kinked, especially when you reposition the mother and it resolves the problem. So there's quite a few things you can do to help determine, but it should be every 15-30 minutes per A1, the Women's Health Organization that sets the standards for intermittent monitoring. The ones that ACNM, MEEC, and ACOG will reference for intermittent monitoring guidelines. And then during labor and pushing phase, 5 to 15 minutes apart for intermittent monitoring. And then obviously, if you have heart tone concerns, you've got complications, you're going to listen more frequently, you're going to do continuous monitoring, you're transferring to the hospital for additional. So there's different instruments to use for intermittent monitoring. Most practices will use a Doppler for intermittent monitoring when you're on a labor and delivery unit and they're using a continuous fetal monitor and just putting it on for 1 to 2 minutes. That's not technically the standard of care and the recommendations. In some home birth practices, especially older school home birth practices, they'll still use a fetoscope, but I would say most practices, they're going to use a Doppler in hospital, birth center, home setting for intermittent monitoring. So the Pinard stethoscope is kind of that fetoscope variation. You have to be able to have skills and training, and a lot of our traditionally trained midwives in the medical system don't have the skills to do it anymore. It's a lost art. It's those direct entry midwives, those granny midwives, those home birth midwives that have the knowledge and skills to use fetoscopes, to use a Pinard stethoscope anymore. There's the pin stethoscope. It's more of a horn, bell shape. It has a variety of diameters from 12.5 centimeters to 16.5 centimeters, and it depending on the choice of the individual Pinard maker. Early Pinards were produced out of wood. More recently, they've been plastic or aluminum. Wood still is the preferred option because it conducts the sound better. Inexpensive. Great in third world countries where you don't have Dopplers, you don't have electricity, you have challenges and barriers. So when I talk about things, like sometimes I'm referencing more the United States because that's what I'm more familiar with, but around the world they use the resources that they have available, and fetoscopes and these specialized stethoscopes for fetal monitoring work just well if you have the proper training skills. Delay stethoscope, the fetoscope that we're more used to in the United States. It was developed in 1917. An American physician with Dr. Hillis and Dr. DeLay created it, and it's definitely used in the United States in home births. I just haven't seen it anywhere else anymore. So you got to be able to have the knowledge and skills of how to use it. I've had a fetoscope. I've never personally had anybody that's able to train me. I've tried during prenatal visits to practice, and I just couldn't hear and do it, so I wasn't comfortable during labor. I would only use a Doppler, and I would explain to the families, like, if you really want a midwife that has these skills, here's my colleagues I can refer you to if it's really important during the entire pregnancy birth. We don't use a Doppler. We don't have those sound wave exposures for your baby. I just don't have the knowledge and skills to assess your baby during labor comfortably with a fetoscope. So it's definitely an inexpensive option, and it's a great resource. It's not attached to batteries and a technology. And I think, especially in midwifery, we're losing more and more of those beautiful skills and knowledge and resources that we used to have in the past, and we're so dependent on technology. And if it doesn't exist, we're going to be very vulnerable. So this is the one that's most commonly used for intermittent monitoring in all birth settings, a handheld Doppler. They range in prices. I've seen the low end, like Amazon parents can get them for $30 to $50, but they're not nearly the quality that a midwife, a healthcare practitioner is going to use during labor. The hertz aren't as good. There's artifacts. You want to be confident. So most of the ones people will use are $400 to $800. So they're very expensive. You want to get the one that's waterproof, especially if you're doing water births. And waterproof doesn't mean you could just submerge the whole machine. You just have to, the probe itself can go in the water, and you just got to be super careful of the actual monitoring machine. So a handheld Doppler, there's various sizes, there's different hertz, there's different things to consider depending on the brand and the company and what you're comfortable with. There's techniques for getting the monitoring based on the baby's position, the mom's position, what stage of labor versus prenatal, but during intermittent fetal monitoring is during active labor at their home, the birth center, or hospital setting, and you want to be getting it for 1 to 2 minutes during or right after that contraction, because your goal is to get that's part of a fetal monitoring strip where you're recognizing late decelerations, you're noticing variables, you're noticing prolonged decelerations of the baby's heart rate. You want to find the signs of cord compression, placenta insufficiency, and oxygen deprivation to the baby. So you want to explain to the mother the options and choices you have in positioning and the timing of the standard of care and how to document it, and how to listen, because there is a difference of how it sounds with an actual heartbeat of the baby. It's a galloping horse, dump, ba-da-dump, 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 versus you're getting blood vessels of the placenta, and it's more of a shoo, 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 shoo. And you have to be super careful, because that shoo, 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 that could be mom's femoral arteries right next to the baby when you're, especially in the pushing phase, and you're in that lower pelvis of baby, and you're in the Doppler is right over the pubic bone. You have to be very confident you're getting baby over mom, because I can tell you over and over and over again where people are assessing during pushing and thinking they're listening to baby, and the baby comes out and it's been dead for a while, because the entire time they were monitoring mom and not baby. So we have to be able to have clear distinctions. There's simple things you can do. You can check mom's heartbeat. You can have a pulse ox, you can do a radial pulse. Is the heartbeat with that the same heart rate as the mom, or is it different? So then those are ways to document and defend yourself, that yes, I'm confident I'm getting baby. Mom's heart rate is 80s, baby's heart rate is 130s. Mom and baby are almost identical. I'm going to try to do some positions and reevaluate to confirm, yes, I'm getting 90s on mom and 90s on baby. I need to start doing resuscitation measures, repositioning, oxygen, fluid, preparing for delivery or preparing for transfer to a hospital if you're not already in one. So you have to, this is pretty much our only vital sign we get for the babies, and we have to be confident and skilled and qualified to do a Doppler intermittent fetal monitoring, because it's the only way to get the baby's heartbeat until they're. So it's our So we already talked about getting the mom's heartbeat the same time as getting the baby's. If you're ever questioning it's low, but if the mom is calm and relaxed and her heart rate you got an hour ago was 60s and you're getting 150s on the monitor, you're pretty confident you're getting the baby versus the mother. So you don't want any ambiguity. You don't want any questioning, the heartbeat's going to change. It's going to have bounce to bounce change of variability. You're going to go from 132 to 137 to 130 if it's showing the number versus you're just listening. That's normal, that's healthy, that's reassuring. But what gets concerning is it's 130 and then all of a sudden 5-10 seconds later it's in the 60s and it jumps right back up, and then you think there's a cord compression, a variable. It goes down and it just doesn't come back up. Like, that's when as midwives our hearts just sink. You hear dum dum dum, and you're like, I know that's baby and this is not good. And so it's like comparing to us. If your normal heart rate is 60 to 100 and all of a sudden now your heart's going at 20, 30, that's going to stress you out. So it's important to understand a normal range for a baby's heart rate is 110 beats per minute to 160 beats per minute. So we have to think about baseline. So if I have someone that's normally running 110 for baby and all of a sudden they're 90s, 100s, that baby can compensate a little bit more because it's not a drastic change for that baby, versus I have a baby normally been running 160, baby questionable, starting to creep up because of a fever, and now I'm getting 90s to 100. That baby has a drastic change in its heart rate, and it's far more stressed out and complication risk than someone that's just a slight change from its baseline norm. So you're going to count 6-second intervals for 30 to 60 seconds, and then you're going to times it by 10 to get your beats per minute. You're going to determine, are there accelerations, are there decelerations, if there are decelerations, what type? Are they earlies, are they lates, are they variables, is it prolonged decelerations? Variability, accelerations, wiggly babies are very reassuring signs of well oxygenation. Minimal movement on baby, minimal change in variability, and decelerations that are late and variables and prolonged are concerning, and you need to do things about them. So we have to be able to understand the differences. If you notice on continuous fetal monitoring, it's going to give you far more information. It's going to give you the bounce to bounce change. It's going to give you the variability, the tracing. It's going to get the mom. It's going to get her contractions. When we're in out of hospital setting and we're doing intermittent monitoring, we touch their bellies to feel the contractions in conjunction with what the mom is telling us they're feeling. We're putting the Doppler on at the right timing, and we're getting a glimpse of hearing what would have been on that tracing of a continuous fetal monitoring. So our goal is to find those variables, those late decelerations, and those prolonged decelerations that cause complications to the baby. So recommendations when considering intermittent monitoring: your skills, the risk factors of the mom, the birth setting you're at, the potential complications, the different types of equipment, the standard of care in your local area. There are great guidelines of intermittent monitoring standards that you should be following, because if there's ever a question of care standards or a court, it's going to be held to the A1 standards of intermittent monitoring. You're going to want to do 61 to 2 minutes for the tail end of that contraction to the end of it, because you want to get that glimmer of time of where that late deceleration could be, because it could be very subtle, and so you don't want to miss it. And you want to do it in early and active labor for 15 to 30 minutes, and then you want to be doing it during pushing phase for 5 to 15 minutes apart. And so, yeah, definitely understanding the contractions and the timing, because you want to be able to confidently correlate when you're hearing, because an early deceleration that mimics the contraction is completely different than a deceleration, a dip in the baby's heartbeat after a contraction. They have completely different meanings of what the baby is trying to communicate with. Fetal movement, wiggly babies are happy babies. I stress it all the time. I was like, you can't have a happy baby and a sad baby. The few exemptions, it was happy and then it kinked its cord. It didn't get oxygen supplies. It wasn't happy, but then we resolved the problem, and now the oxygen is good and the baby's happy again. So cord compressions are easier versus placenta insufficiency. If you can resolve the cord compression, like, there's variations of complications. So like, you could have an occult cord where the cord gets kinked by the baby's head when it's delivering, and the only way to resolve that is to do a C-section, a quick delivery, because you can't reposition the baby to get the baby off the side of the cord against the head. You just have to deliver quickly. So there are times that you have to deliver imminently, whether it's by C-section or telling a mom to push really hard, because that cord's being compressed and repositioning is not going to resolve that. You want to be able to differentiate between the mom and baby's heartbeat. It's so important. Where the Doppler is on this picture, your chances of getting mom are pretty unlikely. It's when you start getting to that pant line, that lower pelvis, the linea nigra, and that mid, especially the left and the right part of the pelvis, you got the femoral arteries, you got the pudendal vessels down there, versus like, is that mom, is that baby, especially when they're pushing and she's moaning and groaning and she's squatting and she's hands and knees and she's in the water and you're getting artifact. You have to feel confident during pushing that you're listening to baby and it's accurate versus you're so there's different findings that we talked about. You get a low heartbeat for various reasons. You get a fast heartbeat, a baseline. So if it goes faster than 160, it's called tachycardia. If it's less than 110, it's called bradycardia. And a change for baby's baseline. Like, just because you went from 160 to 110, that baby, that is a drastic change. Even though it's quote unquote the normal range, that would concern me. If I had a baby in the 160s and all of a sudden I am getting 130s, 120s, 110s, I'm going to watch it pretty closely. Are there signs of other stressors? Are there decelerations, variables? Is this baby having a change in baseline? But you have to, just because it's quote unquote in the normal range, is this the normal for that baby? Abnormal monitoring, there's different things to talk about depending on your birth setting. If the heartbeat is low, you're going to do intrauterine resuscitation measures. You're going to do IV fluids, repositioning, oxygen, slow deep breaths, looking at the underlying potential causes. If there's fast heartbeat, you're going to talk about, is there signs of infection? Is there some other stressor? Because too many times we think, oh, the baby's got oxygen stressors only if it's low. You can get fast heartbeats and different stressors. The baby's, especially during pushing, the heartbeat will be high, because the baby's trying to compensate, and then all of a sudden it crashes to bradycardia because during pushing, it couldn't compensate anymore. So if you're getting prolonged bradycardia, tachycardia, deceleration concerns. If it's home birth center, you're going to transfer to the hospital to do continuous fetal monitoring. If you're in the hospital setting, you're just going to pivot from intermittent monitoring to continuous fetal monitoring and try to get to the root cause of the problem. Vaginal exams, sometimes you can have a fast descent, a fast delivery that stresses out the baby, and that's usually an easy thing to solve because you just prepare for delivery and have a baby. And then you can have meconium. It usually doesn't stress out the baby until they're born and they try to breathe on their own, but it's usually like, what are the underlying concerns? Placenta insufficiency, hypertension, placenta abruption, drug use during pregnancy, blood pressure issues, things that can make the placenta post-term, and there's calcifications present on the placenta. There's a lot of things. You want to simple change positions, because if you change positions and the deceleration resolves, it was a cord being kinked, and then you just avoid the positions that cause those complications. Sometimes it's a bearing down, like they could be on the toilet and their blood pressure goes down and they're close to fainting. That decreases the blood flow to the baby, and so you want to get like an alcohol swab. You want to get her good oxygen, give her oxygen mask, IV fluids. So epidurals, the blood pressure can go down. There's medicine, ephedrine, that the anesthesiologists sometimes give. That's why we give lots of fluids before the epidurals, because we're trying to prevent, if the mother's blood pressure goes down, the baby's heart rate tends to go down. If she's having anxiety and pain, she's short of breath, she's not taking good deep breaths, it's going to decrease oxygen to mom, is decrease oxygen to the baby. So we need to be like this art of calm and confident and encouraging slow deep breaths as we're taking care of these other interventions. If it's a placenta abruption and it's a prolapsed cord, like, you just have to do a C-section. You can't resolve it any other way besides the lifeline to the baby. The placenta is not there anymore and the cord's being kinked and can't resolve until the baby delivers. So there are going to be situations where it's just a C-section. Determining what type of deceleration, is it a early, a late, variable, or prolonged? Are you having an irregular rhythm? Is there some sort of like heart rate irregularity occurring with the baby? It's far less frequent, but that may be a case. You definitely want continuous monitoring so you can evaluate it further. And then just determine, intermittent auscultation is great for low risk healthy women, but if you don't have a low risk healthy woman anymore, you need to switch to continuous monitoring. You need to do your interventions accordingly. So as an overall conclusion, auscultation is a great option. We've been doing it since the 1800s. We can't ask the baby how they're doing. We can ask the mom, we can communicate, but this is the only vital sign we can get of the baby during labor. And so we need to be able to use our skills and our training to accurately detect early and significant changes in the baby's heartbeat with intermittent and continuous monitoring, because hypoxia is not something that we want our babies to be exposed to for long term. I get it. They are built to be tough and they don't need the oxygen we do compared to an adult, but they still need oxygen. So we have to watch for those lates. We have to watch for those prolonged decels. We have to watch for tachycardia. We have to get to the underlying potential cause with our interventions and our plans and skills to keep a close eye and prevent those things from happening. So there's many different ways to do intermittent monitoring, and so I just want you to document well. I want you to have the knowledge and skills. I want you to know when it's appropriate to do intermittent monitoring and when it's not. When is it appropriate to transfer from home to birth center to the hospital based on your findings, and when in the hospital setting to get more aggressive with your interventions, continuous fetal monitoring, repositioning, prepping for a C-section.